Hi. The purpose of this tutorial is for the learner to review all aspects of reading electrocardiograms, from the very basics up to the point of being able to be certified to read triage EKGs in the emergency department. The review will start with the really very basics, things you learned your first rotation in medical school, but then we'll proceed through core concepts to the ability to trace and identify tracings which need immediate action, and also those in which the tracing gives you important information short of activating the cath lab. Let's get started. What does this tracing show? This is a normal EKG. The vast majority of tracings you will be asked to read will be normal, or essentially normal. What do you look at to determine that this is true? Generally, the elements of the EKG you look at are the rate, rhythm, axis. Look for hypertrophy. Notice the intervals, see if there are bundle branch blocks. Look to see that the QRS and P waves appear normal. Then look for ST or T wave abnormalities suggesting ischemia or infarction. And then there are several other elements of the EKG that we will discuss as we move on. First, let's go over some really basic things. Remember that resting myocardial cells have a negative charge. As the cells depolarize, the change to a positive charge comes down across the precordium in the direction of the heart's depolarization. And remember that the movement of a positive charge towards an electrode, in other words, the depolarization of the heart, is recorded on the EKG as an upward deflection of the tracing. Correspondingly, if the charge is moving away from an electrode, that would be recorded as a negative tracing. And of course, you'll recall that the leads of the standard EKG are arranged in two planes. The first is if you were facing the body from the front and tells you whether the direction of the charge is to the right or the left, towards the head or the feet. These are called the limb leads. The leads could be thought of as cameras on the heart, or points of view. Leads 1 and L show the heart from the left. Leads 2, 3, and AVF show the heart from the bottom, and lead AVR looks at the heart from the standpoint of the upper right side. The leads could also be imagined as windows on the heart. You can see the direction of the impulse coming as if you look through a window at them. If the limb leads are in the plane facing the patient, then the chest leads are a cross-section of the chest. They are also windows of the heart and record the direction of the heart's depolarization from the viewpoint of these several points across the chest. The limb leads and chest leads together form the 12-lead EKG, and together they show us the exact direction that a depolarization or a beat takes as it travels through the heart. In this case, that direction, that axis, is normal. How do we know that? Well, we know that the normal position of the heart in the chest is inferior along a vertical axis and somewhat to the left across the midline. We also know that the normal heart depolarizes from the sinus node in the upper right of the atrium, down through the atrioventricular node, more or less in the center, and then down through the ventricles along the axis of the heart in a downward and leftward direction. So remembering that a depolarization is recorded on the cardiogram as a positive deflection, as we see here, the normal depolarization of a normally lying heart will have a normal downward leftward axis as shown in this slide, and it will result in positive deflections in both the inferior 2, 3, and AVF and lateral 1 and L leads. That makes for the famous 2 thumbs up sign. Up in 1, up in AVF, 2 thumbs up. I stole the image, but here I am giving credit for it. Let's take a moment now to look at the different axes. We've discussed the normal axis, down and to the left, the 2 thumbs up, shown in the green area. If the axis were directed further to the left and upwards, so that the deflection were still positive in the left leads, 1 and AVL, but were negative in the inferior leads, AVF, we would call this a left axis deviation. This could occur if the ventricle were hypertrophied, or if hypertrophy displaced the heart's position in the chest, or from various abnormalities of the conduction fibers, as we will discuss shortly. For now, recognize that a positive deflection in 1, meaning deflection towards the left, and a negative deflection in AVF, meaning deflection going away from the inferior leads, is read as a left axis deviation. This cardiogram shows left axis deviation. The deflections are positive in the left lateral leads and negative in the inferior leads. There is another finding as well, which we will discuss shortly. Look again at the famous Dubin diagram. In the pink quadrant, we see a positive deflection inferiorly. However, the usually positive deflection to the left in 1 is now negative. This could be seen in lead reversal. And if you see a negative deflection in 1, that should be your first thought, that the limb leads were reversed. A true right axis deviation is rare, but it does occur, and it can be seen in lung disease and other conditions. A negative deflection in 1 with a positive in AVF is a right axis deviation. This tracing shows a right axis deviation. The deflections are negative in 1, but positive in the inferior leads. This is a true right axis. The tracing also shows another finding which can lead to a right axis deviation, namely right ventricular hypertrophy, which we will review next. Here is another example of a true right axis deviation. The extreme right axis, with negative deflections in both the lateral and inferior leads, is sometimes called a northwest axis for reasons obvious from the next slide. This extreme right northwest axis would only be seen in cases where the impulse were generated from a left and inferior site somewhere in the ventricle, and we will see later that it is one of the signs helping us recognize ventricular tachycardia. We're now going to review ventricular hypertrophy. Why would it be important to recognize ventricular hypertrophy? It's been said that other than age, LVH is the most potent predictor of adverse cardiovascular outcomes in the hypertensive population and is an independent risk factor of coronary artery disease, sudden death, heart failure, and stroke. It's also true that right ventricular hypertrophy is one of the most significant indicators of pulmonary disease. Here are two images which tell the same story. When the left ventricle is hypertrophied, as it might be from pumping against an increased afterload in chronic hypertension or in valve disorder, the hypertrophied muscle is reflected in increasingly positive deflection towards the left. More myocardial cells on the left are depolarized. That means that the leftward-looking leads, 1, AVL, and the lateral precordial leads, V5 and V6, will have very positive deflections. The rightward leads, V1 and V2, will show deeply negative deflections as the bulk of the depolarizing cells head away from them. Positive in the left, negative in the right. This is shown here in the right tracings, large positive deflections in 1, L, V5, and V6, with large negative deflections in V1. Notice also that the deflection is negative in the inferior leads. This shows the left axis deviation we just discussed. Look carefully at the tracings outlined in red and correlate them with the visual depiction of a hypertrophied left ventricular wall. Be sure you can recognize this pattern. This tracing shows left ventricular hypertrophy, which with large positive deflections in 1, V5, and V6, and negative deflections in V1 and V2. The tracing does not show left axis deviation in this case. Not every LVH tracing does. There are also T-wave changes, which can be common in left ventricular hypertrophy, may also be seen in ischemia, as we will discuss later. Right ventricular hypertrophy is usually seen with the right ventricle having to pump against an increased load in the pulmonary circulation, such as might be found in chronic lung disease, acute lung disease, sometimes in a pulmonary embolism, in pulmonic stenosis, or with primary pulmonary hypertension. It is recognized by a markedly positive deflection in the rightward-looking leads, primarily V1, also V2, and negative deflections in the lateral leads, 1, AVL, and V5 and V6. Look at the V1 lead, shown in red. There is a large positive deflection for V1. Notice also that the negative deflection in L means right axis deviation. This is typical in right ventricular hypertrophy. Here is just one more image showing the same thing. Right ventricular hypertrophy, positive deflection in V1. This is a classic right ventricular pattern with a very positive V1, very negative V6, negative 1 showing right axis deviation. Be sure you can look for and recognize these features. Remember that the electrical impulse coming from the sinus node and through the AV node is transmitted to the two ventricles via two bundle branches. The presence of a bundle branch block can be seen from looking at the tracings in the precordial leads. This indicates the two ventricles activated by separate bundles of conducting fibers, normally activating at the same time. Now let's imagine that the left bundle has been blocked. That means that left ventricular activation will be delayed. Ventricular activation will then proceed first down the unblocked right bundle. This will lead to initial activation of the right ventricle. Depolarization of the left will be a bit delayed. Only after the right ventricle is depolarized will the activation spread with the delay across to the left ventricle. That means that the left ventricle will be activated in a delayed fashion. Now we remember that the part of the tracing which corresponds to ventricular activation is the QRS complex, and that the normal QRS complex is shorter than 120 milliseconds, or 3 small boxes. So because the left bundle is blocked, left ventricular depolarization and activation are delayed, and the QRS is therefore prolonged to greater than 120 milliseconds. It is called a wide complex. Because it is the left side which is delayed, the latter phases of activation are seen in the left lateral leads, thus giving the typical wide positive complex in V6 with the corresponding wide negative complex in the rightward-looking V1. So while it's not necessary to remember the details of that derivation, it's important to be able to recognize the typical left bundle branch block pattern. It's a QRS duration of greater than 120 milliseconds, a wide complex, with a large positive deflection in V6 and a large negative S deflection in the rightward leads V1. It's worth recognizing left bundle branch block. It's seen in many conditions: structural heart disease, hypertrophy, dilatation, ischemia, cardiomyopathy, and many others. Now let's take a look at the right bundle branch block. If a right bundle is blocked, initial activation will proceed through the left bundle. There can often be a small initial charge across the septum, but with the right bundle branch blocked, the depolarization then proceeds first down the left bundle. This is shown in this current schematic. Left bundle depolarization then leads to left ventricular activation, while the right side is still delayed. Only after the left side is activated will the right side activate in a delayed fashion. This delayed right ventricular activation is shown schematically here. The initial septal depolarization can give a very small positive R in V1, with perhaps a tiny negative deflection in V6. Next, the left ventricular activation gives rise to the negative deflection in V1 and a positive deflection in V6. Finally, the delayed depolarization and activation of the right ventricle, leading to a delayed positive wave in V1, is called R'. And you also see a late negative S wave in V6. This is the typical right bundle branch block pattern. Notice then the typical rabbit ear RSR' pattern in V1 and the typical delayed S wave in V6. Take a moment to recognize this typical right bundle branch block pattern. Right bundle branch block can be a normal variant, but it can also be seen in pulmonary disease, and there are other causes. It's readily recognized once you've taken a look at it. Once again, a brief visual review of the typical abnormalities seen in both right bundle and left bundle branch blocks. Take a moment to review the normal tracing, the right bundle branch block, and the typical left bundle branch block. This is a right bundle branch block pattern, and this is also a right bundle branch block pattern. Now we're going to touch briefly on what are called hemiblocks or fascicular blocks. Look at the image and recall that the ventricles are activated through the right and left bundles. Now remember that the left bundle is actually composed of two separate subbundles, usually working together. These are called fascicles. There is an anterior bundle and a posterior bundle, sometimes called superior and inferior. They're also called fascicles. Here is another diagram of the same idea. The left bundle branch block, LBB, divides into a left anterior fascicle and a left posterior fascicle, labeled here as LAF and LPF. Now take a moment to study the diagram. This is a cross-section of the left ventricle from below. The lateral side is to the body's left, the septal side to the body's right, to the body's middle, from our point of view. Notice the left anterior fascicle. If it is blocked, shown here as dimmed out, then the initial deactivation of the ventricle will go through the posterior fascicle. This will lead to activation of the heart from the inferior aspect, moving superiorly and laterally to the left. Therefore, note that the inferior leads will record a negative deflection as the depolarization moves away from them, and the lateral leads will record a positive deflection as the depolarization heads toward them. A left anterior fascicle block, then, gives a left axis deviation. Right bundle branch block with a left axis deviation means that there is a left anterior hemiblock. Now look at this rendition of the left ventricle, again from below, with lateral to the patient's left. In this case, it is the left posterior fascicle which is blocked, shown as dimmed out. Activation goes first through the left anterior fascicle, the one which is not blocked. This would lead, in turn, to activation proceeding from the front and left and down and to the right. This will lead to a positive deflection in the inferior leads, but to a negative deflection in the lateral leads. Take a moment to recognize this as the typical right axis deviation pattern. Therefore, a right bundle branch block with a right axis deviation comes from a right posterior fascicle block. This is a diagram of the two patterns shown side by side. Take a moment to recognize the patterns and to try to visualize why they would occur in this way. Right bundle branch block with a left anterior hemiblock will be seen as a left axis deviation. Right bundle branch block with a left posterior hemiblock will be seen as a right axis deviation. We're now going to move into those findings that we have to immediately recognize in triage to activate a code STEMI. After all, that's the real reason that we're shown EKGs at triage. We've reviewed a lot of material now, though, and you may want to take a few moments to break before going on. If you want to put the machine on pause and come back, that's fine. As we all know, elevation of the ST segment is the immediate indicator of infarction of the myocardium. Decreased blood flow, ischemia, which has not yet progressed to cell damage or infarction, can be indicated with T-wave inversion. As we covered extensively during the section on axis, each part of the heart is reflected in a different area of the EKG, and typical injury patterns are shown here: the inferior wall, the anterior wall, with septal and lateral areas. This is simply the result of the normal anatomy of the coronary circulation, whereby specific areas of the heart are supplied by specific arteries. When the left main or left anterior descending arteries, for example, are blocked, the anterior and lateral areas infarct. The right coronary and sometimes the circumflex supply inferior and posterior walls, so blockage of those vessels will lead to inferior or posterior infarction. This tracing illustrates damage in each of the areas: inferior in 2, 3, and F, anteroseptal in V1 through V4, and lateral extension in V5, V6, as well as in 1 and AVL. Notice the ST segment elevation in the anterior leads. These ST segment elevations in the septal leads are elevated, not so much in the laterals. This would be an anteroseptal MI. Here you also see anteroseptal ST segment elevation. There's also some T-wave depression in the inferior leads. These are called reciprocal changes. This might mean that there are multiple vessels occluded. ST segment elevation across the precordium, a very extensive anterior myocardial infarction. Again, extensive ST segment elevations across the entire precordium with reciprocal T-wave changes in 2, 3, and AVF, a very extensive myocardial infarction. What do you see here? ST segment elevation in 2, 3, and AVF. This is an inferior myocardial infarction. We also see some T-wave inversions and ST segment depression in V1 and V2. This could be a posterior extension of this inferior myocardial infarction. Again, anteroseptal myocardial infarction with inferior reciprocal changes. And again, inferior ST segment elevation in 2, 3, and AVF, an inferior myocardial infarction. Remember, don't give nitrates, well, you already know that, in an inferior myocardial infarction. Here's another myocardial infarction with ST segment elevations in 2, 3, and AVF, the inferior leads, but you also see clear ST and T-wave inversion in V1 and V2. Imagine, if you would, that you could flip those tracings over, then you would see ST segment elevation in V1 and V2. ST depression like this in V1 and V2 is diagnostic of a posterior MI. Can also often be found with an inferior MI. This then shows an inferior posterior MI. This patient presented with jaw pain and dyspnea, had no chest pain. The tracing shows a very subtle form of what we were just seeing more dramatically. This is an early, true posterior MI. V1 and V2 have T-wave inversions, which will progress to ST segment depressions. Here are some more images of the ST depression in V1 and V2 that are found in a posterior MI. And here is another example of an infraposterior MI. Again, the ST segment elevations are seen in the inferior leads, but the ST depressions are seen in V1 and V2. Learn to look for these kind of T-wave inversions and ST segment depressions in V1 and V2. They can be seen both individually by themselves with a true posterior, or also associated with an inferior MI. One more true posterior MI with minimal, although non-existent, ST segment elevation in the inferior leads. This is again an infraposterior MI. And one more time, ST segment elevations in the anteroseptal leads, as well as 1 in ABL, with a reciprocal T-wave in 3 in AVFs. This is an anteroseptal MI. Now here we see ST segment elevation. Does this represent a myocardial infarction? Probably not. The configuration of some ST segment elevations suggests that they're not an MI. Some patients, for instance young men, can have a slight upward notch at the beginning of the ST segment, sometimes called a J-point elevation. This is not usually an infarction. One way to remember this is the notion of a clown smile. A frown with the edges down is more likely to be an MI. The smiley face, with the edges kind of notched in a concave up direction, that's more suggestive of benign J-point elevation. These are typical examples of benign J-point elevation in a young man. Slight J-point elevation, somewhat smiley face, quote-unquote, concave upward ST segment. This is not a myocardial infarction. Now look at this tracing. There's clearly ST segment elevation. You can see it, well, where? In the lateral leads, 1, L, V5, V6. Also in some of the septal leads, V2, V3. You even see it in some inferior leads, for instance, lead 2. The STs are coved upwards, smiley face, in most, if not all, of the leads. I guess this could be an MI, but it would have to be in almost every area. Another possibility for a diffuse injury, in other words, an injury which cannot be attributed to one specific artery or another, is pericarditis. One extra clue that this might be pericarditis is that the PR interval is slightly depressed in lead 2. Now, if this were a 65-year-old diabetic man with crushing chest pain, I might not hang my hat on it. Well, that is to say, I might not hang his hat on it, but this tracing is very strongly suggestive of acute pericarditis. This is shown even better in this tracing, which is quite typical for pericarditis. You see ST segment elevation pretty much everywhere, lateral, septal, anterior, inferior. It's hard to imagine a shutdown of all of the coronary arteries at once. Such a diffuse ST segment elevation seen in every lead is very strongly indicative of acute pericarditis. In this case, the PR depression in lead 2 cinches it. Try to remember the pattern. This is acute pericarditis. This is a close-up of the PR depression associated with a concave up ST segment elevation. If seen diffusely, this would be pericarditis. Now let's look at something else. Look at this tracing. Do you see ST segment elevation? No, not really. But you do see deep, concerning-looking symmetrical T-wave inversion across the lateral lobes and across the precordium. Here you see deep, biphasic T-waves in areas of the precordium. Again, look at this tracing. Although these are not true ST segment elevations, this particular finding has a special configuration and it can be quite concerning. This pattern is called Wellen syndrome. Wellen syndrome are deep symmetrical or biphasic T-waves in the face of typical anginal symptoms, and they suggest the possibility of a critical left anterior descending lesion. The pain may well have resolved by the time they get to the emergency department, and so in that case it would not actually need immediate STEMI code activation, but they should not be placed in observation with the eye to stressing them. These patients need early catheterization. This is a potentially very severe lesion, and cardiology should know about this, even though it is not truly an ST segment elevation. These are images of the typical Wellen syndrome. The majority are the deep symmetrical T-waves, but you can see those dramatic biphasic T-waves in the precordial leads. This patient presents with sudden severe chest pain. Do you see any elevations in the ST segments? No ST segment elevations? Well, then can this person be placed on observation and treated as an anginal patient? Here is another patient with a similar presentation, and this is a similar tracing. Do you see ST segment elevation? No. Could this patient be put on observation? This is the typical presentation of De Winter sign. The tracing shows an initial ST segment depression followed by a steep, peaked T-wave. So here's the pattern again. So in a patient with chest pain, even though you do not see ST segment elevation, this patient needs immediate attention. Those tracings show De Winter sign. It's not an ST segment elevation, it's a ST depression with large peak T-waves, but in the presence of compatible chest pain, it's considered to be a STEMI equivalent. It's also highly predictive of a critical LAD lesion. It's been called the widowmaker. So this is a sign of an acute occlusion. Those patients should be treated as a STEMI in the appropriate setting. Now switching gears slightly, it was long thought that you could not call a myocardial infarction in the presence of a left bundle branch block. Sgarbossa set out several criteria which made it possible to predict that someone with a pre-existing left bundle branch block did in fact have a myocardial infarction. The criterion here show a variation from the expected ST segment patterns in the left bundle branch block, in the typical left bundle branch block. Take a moment to look at the differences between the usual left bundle branch block on the left upper side and those with Scarbossa's criterion in the lower right. The ST segment in a usual lateral wide LBBB pattern is downsloping. If you see a positive T wave, and certainly elevation in the ST segment elevation, these meet Scarbossa's criteria for an MI. Notice that in V1, the ST is usually relatively modest. An elevation of greater than 5 millimeters would not be expected, and if you see it, it would indicate a myocardial infarction. So would ST segment depression in V1. In fact, there are new modifications of the older Sgarbossa criteria. I said in the last slide that if the ST segment is more than 5 millimeters elevated, that was an MI. However, new criteria are even more sensitive. The new criteria state that if the J-point elevation is greater than 25% of the S-wave depth, this is an MI, and you don't have to have the full 5 millimeter elevation. In this case, for example, the S-wave is 10.5 millimeters, and even though the J-point elevation does not fully reach 5 millimeters, and is in fact only elevated by 3.5 millimeters, it still is an MI, because it is greater than 25% of the S-wave displacement. The new criteria make it possible to recognize more MIs occurring in patients with a prior left bundle branch block. Here is just one other tracing which might be initially confused with a myocardial infarction. Notice the diffuse high peak T waves. This is classic hyperkalemia. This requires calcium, bicarb, glucose, and insulin, high-dose albuterol. Some would say K-exolate in certain circumstances, maybe dialysis. It does not require activation of the cath lab. Hyperkalemia as it's getting to be a little bit too late. Here's the progression of hyperkalemia through stages of peak T waves with loss of the P wave, widening of the QRS complex, and ultimately a sinusoidal QRS. We saw that in the last tracing. Since we're speaking of electrolyte abnormalities, we'll take a few brief moments to look at the prolonged QT interval. Here are the numerical criterion for prolonged QT intervals. These numbers are usually not memorized because there's a quicker way to estimate. If the QT interval is longer than half of the R-to-R duration, then it is considered prolonged. This is better graphically demonstrated here. On the left you see two R-to-R intervals with the QT interval clearly within the 1/2 range. On the right you see the QT interval clearly going over half of the R-to-R ratio. That would be a prolonged QT interval. Here are some of the multiple causes of QT prolongation. There can be congenital causes as well as acquired hypercalcemia, myocarditis, certain drugs. QT interval prolongation can lead a patient open to a particular kind of arrhythmia called torsade de pointes. Here is an image of torsade. Another longer run of torsade. Here we have types of conduction defects and blocks. We'll periodically encounter heart blocks giving rise to bradycardia. And there can be several types. Some require pacemakers, some nothing more than watching. In general, the immediate response depends clearly on the clinical scenario. So a comprehensive summary can easily be placed on one page. And this slide generally shows it. The image on the top shows two progressive lengthening PR intervals followed by a drop beat. This is second-degree heart block Mobitz type 1, also called Wenckebach. It's generally benign. The second tracing shows no such PR interval. The drop beat comes without warning. In certain ischemic conditions, for instance after myocardial infarction, this could herald a complete heart block. Generally requires no immediate intervention, but we need to let cardiology know about it, especially if the patient is being admitted with an MI. Tracing 3 shows a complete heart block, and in a symptomatic patient we would require emergency transcutaneous or transvenous pacemaking. These are the indications for temporary pacing, for emergency pacing. They're different from those with MI and not. Without an MI, basically somebody who's symptomatic or unresponsive to medication, hypotensive, loss of mental status, etc. In a myocardial infarction, the indications get a little broader because there are several conditions which are heralds of a complete heart block. We would usually not be making that decision completely by ourselves. Very rapid heartbeats can be the most threatening and, for the practitioner, among the most frightening cardiac events, so a systemic approach is needed. For example, this could shorten the patient's life and cost you years from yours. Just kidding. This is a time to sort of pause the tape, relax, and get a cup of coffee. We've basically been through a lot, and when you're back and ready, unpause. So arrhythmias tachycardias can originate basically above the node or below that can be in the ventricle or above the ventricle. And this is kind of an overview, broad overview of the many types of supraventricular tachycardias. Fortunately, I believe they fall practically into essentially three treatment categories, and those are sinus tachycardia, broadly classified regular SVT or supraventricular tachycardias, and those include the reentrance and the ectopic atrials and the nodal tachycardias, and finally the flutter and fib syndromes. I think it's really basically three kinds of treatments. So this is a rapid rhythm. It has narrow complexes. Its origin is above the ventricles, so it would fit broadly into what we've decided was a supraventricular tachycardia. So what is it? Well, this is sinus tachycardia. How do we know? There's a P wave before each QRS. The PR interval is constant. The rhythm is regular. There's no suggestion of extra complexes to indicate atrial flutter, for example. And each individual complex appears like a normal QRS. This is sinus tachycardia. Now, the secret to sinus tachycardia is to figure out what's causing it, because causes can range from benign to life-threatening, and generally include on the threatening side pulmonary embolism, ischemia, myocarditis, as well as fever, sepsis, anemia, dehydration, thyrotoxicosis, and drug or alcohol withdrawal. Then there are less threatening causes such as pain or anxiety. Finally, there are chronic benign syndromes of sinus tachycardia. In order to send somebody home from the emergency department with sinus tachycardia, you need to be sure that you've excluded any of the threatening causes. But that's not really part of the triage sign-off process, so let's move on. This is your more typical SVT. It's regular, narrow complexes, but there are no visible P waves, certainly none that appear to be sinus. This is SVT, and it fits within a number of kinds of SVTs, all of which can be treated exactly the same way. This could be treated with adenosine, or it could be slowed down with diltiazem. So what is this rhythm? Well, it's also regular, also has narrow complexes. However, note that it is at or near a rate of 150, and that they're peculiar sawtooth-like waves. These are flutter waves. This is atrial flutter with a 2-to-1 block, and it has the classic rate of 150. Whenever you see any narrow complex tachycardia at a rate near 150, consider atrial flutter with a 2-to-1 block. You could use adenosine here, but you might well be waiting a long, frightening time for it just to come back to flutter. I would probably slow this down with diltiazem or perhaps amiodarone. The key to identifying this rhythm is to notice that it is irregular. This is atrial fibrillation, and it's common in older adults. We usually slow it down with diltiazem, although there are some instances in which we might try to convert in the emergency department. Usually this requires previous anticoagulation and depends on how rapidly the onset has been. Recognize this rhythm from its rapidity and its irregularity. Now we're going to move away from the generally more benign, narrow complex tachycardias to the potentially more immediately life-threatening wide complex tachycardia. These can be particularly frightening. However, the safety valve is that if unstable, there is always an immediate potential treatment, electrical cardioversion. Let's consider the differential, though, since they are not all the same. This is a general list of potential causes of wide complex tachycardia. The real key here is to differentiate VT, ventricular tachycardia, from any of the less immediately threatening causes, such as a supraventricular tachycardia with a pre-existing or rate-related bundle branch or aberrant conduction. It's not always obvious how to recognize ventricular tachycardia. Contrary to popular belief, a patient with VT can be relatively asymptomatic, sitting up, smiling, just feeling tired, right up until the moment that they become unresponsive or degenerate into fibrillation. Trust me, I have seen it happen. This patient, for instance, is sitting up, feeling generally okay, just a little tired. The machine reads a wide complex tachycardia and a right bundle branch block. Is this SVT with pre-existing or rate-related bundle branch, or is it a VT? Well, here are some of the EKG clues to tell ventricular tachycardia from other wide complex tachycardias. Certainly if you see somewhere a sinus beat which is transmitted and can be recognized as different than the wide complexes, This is evidence that the wide complexes come from below the node, that is, from the ventricle. Isolated sinus beats in the mix are also called capture beats. Here, for example, notice that there's a normal QRS among the wide complexes. This is a capture beat, and it indicates that the wide complexes are of ventricular origin and not supraventricular with aberrancy, as a sinus beat is not aberrantly conducted. Here you additionally see two beats which are in a sense combinations of the sinus beat, made wider or more atypical. These are called fusion beats. Concordance means that all of the precordial deflections are moving in the same direction. That is another indication of a ventricular origin. Positive concordance can be a sign that the wide complex tachycardia is ventricular. So can an extreme right axis, as we discussed at the beginning. As we pointed when we first mentioned the northwest axis, we would only see it in cases where the impulses were generated from an inferior and lateral site somewhere in the ventricle. And so we can see that this is a sign that can help us recognize ventricular from supraventricular tachycardia with aberrancy. There are certain morphologies which can help us sort out VT from SVT. For example, an abnormal rabbit air configuration, that is, an atypical nature of the bundle branch block configuration, may favor diagnosis of ventricular tachycardia. Notice in the upper right panel that the abnormal rabbit ears are suggestive of VT, especially when the first R is higher than the R prime. Notching in the T wave on the ST segment can also favor VT. It's actually known as Josephson's sign. It's a little notch that you see in the descending T wave. So now let's take a moment and look again at this tracing and see what we can conclude about Our Lady sitting up and smiling in triage. Well, there is positive concordance across the precordium. There is a probable northwest axis. And there is an atypical configuration of rabbit ears in V1 and V2. There also, if you look carefully in V3, is that small little notch, Joseph's sign. So this is ventricular tachycardia. And it turns out that this patient deteriorated very quickly, fortunately in the resuscitation room with electrical pads on her chest. She came back to sinus rhythm with cardioversion. It's not always immediately obvious, so you need to learn to recognize the signs of ventricular tachycardia. So no discussion of tachycardia would be complete without a brief mention of the Wolff-Parkinson-White syndrome. And here are Wolff, Parkinson, and White. Recall that WPW patients have an extra conducting pathway, an accessory pathway from the atrium into the ventricle. It's different, separate from, and in addition to their AV node. Take a look at this tracing. This is a typical WPW tracing. It shows a short PR interval, and it also shows kind of a slurred upstroke from the PR interval right into the QRS complex. Now, WPW is dangerous because these people are prone to tachycardia, atrial fibrillation, and supraventricular tachycardia. And it can come in two varieties. The essential point about WPW is that a rapid atrial rhythm, such as atrial fibrillation, can be conducted either through the normal pathway, in which it will lead to a rapid narrow complex, but it can also be conducted through the accessory pathway, leading to a wide complex supraventricular tachycardia. This is a narrow complex WPW tachycardia. This is being conducted through the orthodromic, through the regular AV node. This, however, is a wide complex tachycardia, and this represents atrial fibrillation being conducted down the accessory pathway in the patient with WPW. Now, even though this is actually a supraventricular tachycardia, it cannot be treated with drugs that are traditionally used for supraventricular tachycardia, such as diltiazem, because every one of these arrhythmias is a mixture of conduction through the both pathways. If you further block the AV node, then even faster conduction can occur through the accessory pathway. So this rhythm, looking like it might be VT, should be treated as you would treat ventricular tachycardia. It's helpful to remember because it looks more like VT. You should treat it more like VT. Procainamide would be your first choice. If the patient is unstable, they should be cardioverted. You should not be using something like diltiazem. This is another example of atrial fibrillation being conducted in a wide complex manner through the accessory pathway. And here you see on the top the typical WPW with basically a short PR interval and a slurred upstroke to the QRS, with the arrhythmia seen below, which is a wide complex tachycardia. Again, this should be treated with procainamide, although ibutylide can also be used. There are a small portion of practitioners who will use amiodarone. What is of key importance, though, and it's worth reiterating, is to avoid diltiazem and adenosine. Blocking the AV node can lead to even more rapid conduction through the accessory pathway. Again, if the patient is unstable, you can cardiovert. So the bulk of what you'd usually see at triage is over. Now we're just going to go through a few, rare and unusual EKGs, which you might want to notice, and they could sometimes be important. Patient presents with shortness of breath. Look at the tracing. You see a right bundle branch block with T-wave depression at V1. This is suggestive of right heart strain. You see a deep S1, deep S in 1, and there's a deep T-wave inversion in 3, as well as a small Q wave. There is clear right axis deviation. So consider these findings together and look at the tracing. This is an S1, Q3, T3, right axis deviation, right bundle branch block, and right ventricular strain. This is an acute, hemodynamically significant, most likely, pulmonary embolism. This is a patient I saw very recently, presented with acute onset of dyspnea. There's a rapid rate, there's an S in 1, some T-wave changes in 3, there's a right bundle branch block with T-wave inversion in V1. The patient was placed on heparin before a CT scan, and that revealed a massive pulmonary saddle embolism. He went to the catheter lab for echos, which is catheter-directed TPA, and he did well. This patient presents with syncope, and it looks like he has a right bundle branch block. We've said before right bundle branch block could be normal. But is it? This is an unusual form of a right bundle branch block, and one that you don't want to miss. This is the Brugada syndrome. It has an unusual, particularly strangely slanted right bundleoid pattern in V1 and V2, as well as across the precordial tunnel. So this is somebody who actually can go into sudden death and should be treated very carefully. So that's something to recognize, an atypical, strange-looking right bundle branch block. And this is just another example. This is subtle, but it could be seen. There is an ST segment elevation really in an isolated area, AVL. It's an isolated AVL ST segment elevation. This is suggestive of an MI arising in the circumflex artery. It's interesting, and I don't have a picture of it, but if the ST segment elevation were in AVR, that would be suggestive of left main disease. Notice this peculiar abnormality in the tracing in V1 and V2. There's a little extra blip and a little extra wave. This is called an epsilon wave. It's scary because it's subtle and it can cause unexpected sudden death. It's part of something called arrhythmogenic right ventricular cardiomyopathy, or sometimes called arrhythmogenic right ventricular dysplasia, It's a funny little extra beat called an epsilon wave. It's worth trying to be on the lookout for. Here we have alternating bundle branch blocks. It's unusual. Alternating bundle branch blocks can be suggestive of digitoxicity. These almost look like Wellens, except they're so big, they're so deep, they're so symmetrical. These are actually intracranial T waves, indicative of an intracranial bleed. They're so wide and they're so unusual looking that they're not really typical of a cardiac ischemia. This would be a high risk for an intracranial bleed. This almost looks like a brugada, but it also has a very long, prolonged QT interval. It has wide QRS, prolonged QT interval. This is actually a tricyclic overdose. Prolonged QTs can be strongly suggestive of various overdoses, and tricyclics are one of them. Notice the alternating size or the alternating depth of the QRS complexes, regularly 1, 2, 1, 2, 1, 2, in pretty much each of the leads. This is called electrical alternans. It's from pericardial tamponade, and it's because the heart basically rocks back and forth in the fluid closer to and further away from the recording instrument, the EKG. And this is simply the same picture and demonstrating that the size of the QRS just does indeed alternate 1, 2, 1, 2, 1, 2. So finally, that's basically what we're going to hit on for our review today. So let's reflect on what we've covered. Looking at the EKG, we've learned to check out rate, rhythm, axis, to look for hypertrophy, bundles, and hemiblocks. And that key first glance finding is to recognize ST segment elevation, myocardial infarction, and also ischemic injury. To be cognizant that there are mimics, such as pericarditis, but also warning signs that are not really ST segment elevation, but dangerous nonetheless, such as Wellen sign and De Winter sign. Look for heart block, realize who needs to be paced. Tachycardia can be the most frightening and separates to narrow and wide complex tachycardia. Narrow complex tachycardia needs only to be separated into sinus, SVT syndromes, and flutter-fib syndromes as far as treatment. The wide complex tachycardias can be either a ventricular tachycardia or an SVT with aberrancy, and there are numerous clues to help you determine what is really VT. Certain electrolyte abnormalities need to be recognized immediately, such as hyperkalemia, because they can degenerate fast. And finally, notice some unusual things. Recognize the PE if you can in the appropriate setting. Learn to be suspicious of an atypical bright bundle branch block. It may be brugada. Look for electrical alternans and any of the other things we've discussed. So I hope this has been an interesting and informative review. I'm sure you're going to do great on your tests, and best of luck.